And thank you, Advani sir, for forming a strong background for me. So today, what I am going to talk on the results of the Stampede trial when we add docetaxel to androgen deprivation therapy, whether the tumor has low or high tumor burden. What are its long-term survival results? Does docetaxel work for low tumor burden or high tumor burden? These are the results of the Stampede trial. Next slide, please. Next slide. Next. So what is Stampede? Stampede is a systemic therapy in advancing or metastatic prostate cancer. It's a very innovative trial. It has a multi-arm, multi-stage trial. It utilizes one control arm and several comparative arms in order to provide evidence for inclusion of therapies beyond the standard androgen deprivation therapy. So to introduce this topic, the earlier Stampede trial, the docetaxel comparison arm in the primary analysis showed an improvement in survival. But here the patients were M0 and M1 were all included. And to this, I'll agree with Dr. Senthil, the M0 arm did not show an improvement by adding docetaxel as an adjuvant therapy. So in what Dr. Senthil and they were discussing, M0 arm in Stampede trial at least did not show by adding docetaxel there was an improvement. And since both M0 and M1 were included, the Stampede trial analyst decided to analyze only the M1 patient's data separately and to give them a flavor of metastatic burden, whether it's low or high risk. Does it make a difference? And of course, this is one of the large follow-up data that they have presented in this study. This was the need of R. Why? Because the earlier two trials, the Chartered and Getted, clearly showed, I would not say clearly, in fact, in a subgroup analysis showed that docetaxel should not be given in low metastatic burden, and docetaxel was useful only in high tumor burden. This gave birth to this study. This was a 1,886 patients, as I told you, only M1 patients. Arm A was androgen deprivation therapy, and Arm C was androgen deprivation therapy plus docetaxel. As you can see, the number of patients, certain number of patients were excluded because retrospectively, when they tried to analyze the bone scans, some of the bone scans were not centralized or they were not reported the way it should be. The patients, the Arm A, as I told you, was androgen deprivation therapy, and Arm C was androgen deprivation therapy plus docetaxel. And in both the arms, the patients were stratified as per the low tumor burden or high tumor burden. It was defined as per in the Charter trial, which I'll show you in my subsequent slide. The randomization, 20% was according to the hospital site, according to the age less than 70 or above 70, WHO performance status 0 or versus 1, 2, nodal involvement, negative, positive or unspecified, planned ADT, and usage of aspirin or other NSAID. Metastatic burden was assessed by whole body scintigraphy, CT scan or MRI staging. The high tumor burden as per Chartered trial was whether there was a presence of visceral metastasis or at least 4 bony lesions with at least one outside the vertebral body. The results of this trial show very clearly the overall survival, the results. In the low tumor burden, as you can see here, the median survival was 76.7 months in the ADT arm. But when docetaxel was added, the survival jumped to 93.2, and well, this is in low tumor burden. Whereas in high tumor burden, as you can see, the numbers will be lesser because these are the patients who have high tumor burden, but still there was a significant benefit. The median survival of 35.2 months versus 38.9 months. The 5-year survival also jumped when we added docetaxel to ADT, 72% versus 57% in the low tumor burden, whereas in high tumor burden, there was improvement of 5-year survival by 10%. Next. Next slide, please. And this is just an overall survival curve where you can see the separation, in fact, is much better in low burden versus high burden. And hazard ratio in low burden of overall survival is 0.76 compared to 0.81. Results here of the secondary endpoints in this trial were failure-free survival, progression-free survival, metastatic progression-free survival, and prostate cancer specific survival. As you can see, the hazard ratio in all the secondary endpoints was much better when docetaxel was added to androgen deprivation therapy. These are the adverse events, as you can see, where they are classified up to 1 year or beyond 1 year. If it was within 1 year, yeah, as expected, ADT plus docetaxel, the adverse events were higher, 21% versus 25, 3 versus 13%. But after 1 year, the results, the adverse events were absolutely the same. So here what we saw, that adding docetaxel to androgen deprivation therapy, there was a clear statistically and clinically significant improvement in survival and delayed time to metastasis, irrespective of metastatic tumor burden. The earlier two trials, the J2 and the Chartered, which showed that docetaxel was used only in high tumor burden. Just to give you a flavor of these trials, this was J2 was a trial of 385 patients, and median follow-up was 84 months. Chartered was a study of 790 patients with a follow-up of 54 months. The hazard ratio of adding docetaxel was clearly better. Sorry, this is not no. There was a clear evidence of improvement, and hazard ratio was 0.88, whereas in Chartered it was 0.72. In Stampede, in fact, it was in between. But see, the number of patients in Stampede, 1086, and a very long follow-up of 78 months. In prior subgroup analysis, as I showed you, docetaxel was recommended only in high tumor burden. But what was the reason? In both these trials, 25% of the patients were enrolled as metastatic disease had received previous radical treatment. And we know that that these patients who develop metastasis after radical local treatment have a different natural history than those who present with M1 disease de novo. In Stampede trial, the M1 patients were de novo. 95% of the patients were de novo M1 metastatic disease. And we know that none of the trials where androgen receptor pathway targeting agents that were used, like abiraterone, apalutamide, and enzalutamide, have shown any heterogeneity of effect by metastatic burden. Here, just to revise, in the Stampede trial, we saw the absolute rate in 5-year survival in low metastatic burden, 57 to 72% by adding docetaxel, whereas in high metastatic burden, as I told you, 10% improvement in 5-year survival by adding docetaxel. So to conclude, docetaxel plus androgen deprivation therapy improves the overall survival, failure-free survival in newly diagnosed metastatic hormone-naive prostate cancer, regardless of metastatic burden. It should now be considered as a first-line option, regardless of stratification of disease burden. Thank you very much, and I hope I've finished in my time.